and to the organisers for inviting me here today. So look, today I wanted to talk about public health communication. And can everyone hear me, by the way? Am I clear at the back? Good. So today I want to talk about public health communication. We've heard a bit about interpersonal communication with migrants and multicultural communities. Today I want to really focus on public health communication. So first, I'd like to acknowledge the traditional owners of the land. We're on Ngunnawal land today, and I'd like to acknowledge elders past, present, and emerging. And I'd like to start by acknowledging some context in which I give this talk and in which we sit and consider this dilemma, the dilemma of communicating well to multicultural communities. There have been enormous changes worldwide, most obviously COVID, and we've seen enormous social and economic, sorry, is that not?
Yes, no, sorry, I forgot to share with the people online.
Oh.
My apologies.
Working now?
It should be.
Want to check people online? Can you see the slides now? Hopefully, yes. So as I was saying, there have been enormous changes, enormous social and economic upheaval with COVID. That, just a minute, it's not moving now. How do I get it to move? Ah, okay, press harder. And we've seen massive developments in our media, in social media, in the way we communicate, and with technology, with AI, which have enormous implications for health communication. And we've also, of course, seen the significance of the Black Lives Matter movement, which really has profound implications for the way we think about communicating about health and the demand for justice and attention to the circumstances and needs of people of colour from different racial and ethnic backgrounds. And of course, in Australia, we see the movement towards the voice in the referendum. So it's something we absolutely must pay attention to. And it has implications not only for health communication, but for science more generally and the way we represent diversity in science. And of course, I stand here talking to you about multicultural health as a white woman, and I need to acknowledge that. But I hope what I can do today is share with you the work that we did in partnership with our multicultural communities and the way the learnings and the lessons that we had from that work. So today I want to talk about three areas. I'm just going to move this sidebar down so it doesn't block all my slides. So I want to talk about three areas. I want to talk about the work we did on COVID and public health communication. I want to talk about how we could do that better. And then I want to end by talking a bit about system-based approaches. Oh, slides, it's not moving. I think it's, what happens
when you touch the sidebar? It forgets that you're on the PowerPoint.
All right, okay. So we have seen wide disparities in COVID outcomes by race and by ethnicity in the UK, in the US, in Australia, and in fact in most high-income countries. And outcomes were worse for groups with higher socioeconomic disadvantage, where there were structural barriers, including and importantly racism and marginalisation. And these same groups have lower health literacy. And despite this being a time where we really needed to communicate effectively to all people in our community, we saw a real lack of attention to culture and health literacy in our COVID-19 health communications. And in Australia and internationally, we persistently failed our culturally and linguistically diverse communities in our health communication. We saw national campaigns using language that was confusing and insensitive to different groups, with metaphors and terms that didn't translate to other cultures. And in fact, in the UK, this was described as the perfect storm. We saw multiple problems with translations. We saw failure to translate health information into different languages in a timely way. We saw an over-reliance on machine translations. And even when materials were translated, they were often difficult to find and they were often out of date. And there were few options for people who were non-literate in their own language. We failed to culturally adapt health information. And under here, I say we failed to attend the health literacy of health information. So language, even if it was in the right language, was often too complex and required high levels of literacy and high levels of education. Put this down again. And we saw this in the literature, in the international literature. This is one of my favorite studies from COVID. It was done very early on in COVID, so around June, July in 2020. And what this study did was compare the readability of different official public health information about COVID from websites from agencies around the world, so 15 different countries. And you probably can't read that from where you are, but just to get to the bottom line, text was consistently written many grades above the recommended reading grade for average readers, let alone low literacy readers. So this, in this red line, this is the SMOG index. I've highlighted that because it's most commonly known, but that shows the scores range from 15 to around 11 at the lowest. Most are around 13, 14, or 12 for some, where the recommended reading grade is grade 8. And for low literacy readers, it's grade 6. So none of that information was serving the needs for people with even average levels of literacy and education. So that was very early on in COVID. We repeated this study 18 months later to see if the information had improved. And this is my PhD student, Olivia Mack, who did this nice study. We looked at a subset of websites from from overseas and looking at COVID behavior communication. And again, just to cut to the bottom line, again, we saw exactly the same pattern. Health information was still written far above the recommended reading age. The median grade was grade 12. And in fact, the readability scores were highest for COVID vaccination information. And that was at a time when we were trying to rapidly roll out the vaccine program. So we were still doing a pretty bad job. So what were the consequences of poor quality information? Well, my lab and researchers around the world did research on this area. And what we saw was that among people with lower health literacy and from some culturally and linguistically diverse groups, particularly those who were socially disadvantaged, we saw lower knowledge of COVID symptoms and prevention. We saw higher levels of confusion and difficulty in accessing information. We saw lower risk perceptions, increased belief in misinformation, lower willingness to comply with restrictions, lower willingness to vaccinate, higher rates of COVID infection early on in the pandemic when it was most risky to be infected. And of course, as I showed you, we saw higher mortality among some migrant and culturally diverse groups. So it matters. Good communication matters. So how can we do it? How can we do it better? Well, there's lots of good advice about how we can do it better. And I have distilled this down into kind of 5 key elements of good cross-cultural public health communication. And I'll just go through each of these briefly. So I don't need to talk to this audience about the importance of co-design. Of course, we need to do co-design. And not only is it a good thing to do ethically and morally, but also we now know from the data that if you use co-design methods, the information you produce is more readable and understandable for consumers. Of course, we need high quality translations and we need to follow high quality processes. We need to use accredited translators. We need audio and visual options for people who are not literate in their own language. Information must be easy to find. It needs to be up to date. And machine translations are currently problematic. It may be that we may be able to work with them in the future, but at the moment they're not accurate enough. We need to use health literate document design principles. So that means using plain language, avoiding jargon, avoiding polysyllabic words, writing at grade 8, reading level or below, using simple font. And we know that if people find text easy to read, they judge it more favorably, they're more likely to say they're willing to follow the advice. And in fact, simpler documents are easier and faster and more accurately translated. And there are also tools now to support health literacy document designs, the PMAT, which is available on the AHRQ government website. And our own lab has developed the Health Literacy Editor, which is an online tool which you can copy and paste text into, and it'll give you guidance about readability, complex words, jargon words, and how to replace those with more familiar terminology. And of course, we talk a lot about knowledge and information, but we need to think beyond knowledge. We need to think about capability, opportunity, and motivation. And of course, we need to follow guidance for culturally sensitive communication. And there's good advice available. So that advice, just to summarize, says we need to tailor messages to reflect sociocultural norms, influences, and different drivers of behavior. We need to understand the structural barriers. So if people have no sick leave or shared bathrooms, we need to understand the different response costs in different communities. We need to address issues of trust and credibility, especially where it's low. And that means having multiple credible community sources, not only faith leaders, not government. We need to link to social identities that reflect the diverse community. And we need to understand, importantly, the differences within and between cultural groups and not lump people together. Ideally, we want to use evidence tailored to specific cultural groups when we communicate, include stories and real-world examples. Avoiding fear is important because it can result in denial and avoidance, especially in low control contexts, and avoid stigmatization and blame of groups. And importantly, we need to act through active multicultural networks with existing knowledge, existing relationships, and trust. So I now want to talk briefly about some research that we did with the multicultural communities in Western Sydney. You can see that this is a partnership where we try to apply some of these principles. And this partnership was built on an existing collaboration that our lab has with the Western Sydney Local Health District. That's an area where there's considerable cultural and socioeconomic diversity in Sydney. And we partnered with our multicultural health services and integrated health on this project. And really, this project was stimulated by a survey that we did very early on in COVID. So this was in April 2020. We conducted this large Australia-wide survey, which showed that people with lower health literacy and who spoke a language other than English at home had poorer knowledge of COVID, more difficulty finding and understanding government messaging about COVID, and were more likely to endorse misinformation beliefs and lower vaccine intentions. But in this survey, our culturally and linguistically diverse sample was very small. It was only 6%. And our colleagues from Multicultural Health said to us, these findings replicate or are consistent with what we're seeing on the ground, but we need more evidence. We need to understand this better using better measures and larger sample. So we developed a community survey of 11 cultural and language groups. We ran that in Greater Sydney. We managed to recruit 708 participants, and that still remains the largest multicultural survey in Australia on COVID. This work was done in parallel with some community engagement work, which was run by Dipti Zachariah, who was the multicultural health lead. I don't have time to talk about that community engagement work, but if you want to read about it, it's been published in the Journal of Health Communication, so you can read about it there. But what was nice about this work was the research work and the community engagement work fed on each other and informed each other in a really nice way. So I'm going to talk to you a bit about the findings, our findings from our survey. So in terms of our methods, the survey was co-designed with our local health district staff. We had 10 language groups, 11 cultural groups selected. All the surveys were available in English, and also were translated. We had our participants were over 18 and who didn't speak English as their main language at home. And in our analysis, we weighted the analysis to reflect the population distribution across our local health district. In terms of our participants, you can see we had diversity in terms of our gender, age, education, and health literacy. I don't know if you can see that. I don't know if you can. Sorry, I'm going to move this to the top now. And we had diversity in terms of the different language and cultural group where people came from. Most people were born overseas, and a high proportion had low English proficiency. So we got a diverse sample here in this survey. So what did we find? Well, we were interested in where people got their COVID-19 information from. And what we found was that people got their information from many different sources. Not surprisingly, those sources varied by demographic characteristics. So for instance, not surprisingly, younger people were more likely to get their information from social media. Older people were more likely to get their information from the community, friends and family, or overseas. We saw large differences between the different cultural and language communities and where they got their information from. So you can see here around a third of our Samoan and Tongan group used official sources compared to over 90% of our Khmer group. And you can see differences again here. This is a large difference in terms of whether people got their information from overseas. Our Croatian group, almost 100% got their information from overseas, whereas that was much, much lower for the Khmer group. And there were many differences like this. We also saw differences by health literacy. So people with lower health literacy were less likely to use official sources and were more likely to use friends and family or overseas information, and were more likely to get information in another language. And we also saw that finding information about COVID that's easy to understand was harder for people who are older aged, who had lower health literacy, and who had poor English proficiency, and for some of the cultural groups in our survey. And not surprisingly, COVID risk perceptions varied. Let me move this up again. COVID risk perceptions varied by group. COVID testing intentions varied. This graph shows vaccine willingness, and vaccine willingness was very different across the different cultural and linguistic groups. And also we saw barriers to getting a COVID vaccine that also reflected information gaps. And what was very useful about this survey is the results came in about the time of the Delta outbreak in Western Sydney. And I don't know if you remember, the focus of attention was on Western Sydney. So our results were able to feed into the Ministry of Health response. And it led to a redirection of funding into the community engagement work, which was working on the ground with trusted and trained community advisors and what they call vaccine safety champions, conducting education, community forums, consultations, vaccine education sessions, and developing co-designed resources. So it was a nice example of the way that research and community work fed into policy and then actually did change practice. Probably it'll never happen again in my lifetime, but it was nice that it happened once. And this is just some examples of some of the resources that were developed by the community engagement team. And I do encourage you to read that paper by Dipti and her group. So in summary, the results provide evidence of a very wide variation in knowledge, attitudes, beliefs, and behaviours between different communities. And it showed to policymakers that one-size-fits-all approach was just not possible. It highlighted the need to really diversify the communication channels, to focus on community-based and local responses, And look, ultimately, this approach was very successful, combined with the community engagement work, and there was an over 90% double vaccination rate was achieved in Western Sydney relatively quickly. And considering it's such a socioeconomically diverse and culturally diverse area, that was really impressive. But I guess, thinking about this more broadly, although nationally and internationally, we saw pockets of good practice, it mostly relied on either individuals or individual organizations doing good work. There was no system-wide approach. And of course, we need a system-wide approach. We need this to happen at scale. It needs to happen everywhere to adequately service our multicultural communities. It can't be an afterthought. It can't be something that's just nice to have. So that's led me to think about much more about taking a system-based approach when we think about multicultural communication. And I guess here I come back to health literacy and the definition of health literacy. And the definition of health literacy is that it's the personal skills, competencies, as well as the organizational structures and resources that enable people to access, understand, appraise, and use health information to promote and maintain their health. And of course, multicultural health communication really needs to be at the heart of that definition and approach. And all people, regardless of their cultural or language background, and in fact, regardless of any dimension of diversity, should be able to readily access information, understand it, appraise it, and use it to better their health, to look after their health. And I guess I'm encouraged by the shift towards international frameworks, action plans, and strategies for health literacy. And as Peter said, I'm involved in the Australian National Health Literacy Strategy at the moment, which is currently in development. We're hoping to bring some of these learnings into that strategy. But of course, you know, strategies are only useful if they're resourced, if they're supported by guidelines and standards and incentives and education and training. Otherwise, they sit on a shelf and gather dust. And I'm also encouraged by the work of thinking in a much more system-based way about health literacy and multicultural communication. And this is a really nice model, I think, put forward by someone called Christine Sorensen, who's a health literacy researcher in Europe. And she talks about the micro, the meso, and the macro levels that we need to think about to really change our organizational structures and the way we provide services to our communities from different cultures and with lower health literacy on different dimensions of diversity. And it really it emphasizes that we need to think about all these different levels shown in this figure here if we want to achieve health, what I would call health literate and multiculturally responsive services. So look, I come away from it feeling like there's an enormous amount to do. There's an enormous amount to do to improve the way that we respond to our communities. But at the same time, I see this as a real time for opportunity. I've never seen such public and political recognition of the need for effective communication. So I think the time is now. We need to leverage this time to do great research and change policy and practice. So look, with that, I think I'll finish. I'd like to acknowledge my colleagues at the lab and my multicultural colleagues who I work with very closely on this work. So thank you.